Hello. We are able to hear now. So as you know, today our topic, the other parts of the head and neck oncology we are going to take here. Of course, these are not very important for your exam orientation, but very important for your understanding. So that's why we are going deep a bit more. Salivary gland is a chapter that is given in your regular UG textbook also. You can read that, but this is an over salivary glands like 1200 are there all over the upper aerodigestive tract. As the size of the glands decreases, the malignant ability increases. The malignant ability increases. The malignant ability increases. That should be kept in mind. That means minor salivary glands, they are more malignant. And most common tumor of the salivary glands is pleomorphic adenoma. Pleomorphic adenoma. Pleomorphic adenoma. This should be kept in your mind. Okay. So pleomorphic adenoma which has got a carcinogenic potential. So pleomorphic adenoma is a benign one which has got carcinogenic potential. And parotid is the largest salivary gland that is present behind the ear. As you should see, it is near to the ear. Therefore, it is called as paraotid. Here is a parotid gland, and you have got the facial nerve in intimate relation with it. That is why the parotid gland is very important for ENT surgeon also. Paraotid. That is why it is called as near the ear. Paraotid parotid gland. And submandibular, as you know, this is the mandible and the coronary process, as you know, all these things. So here will be the submandibular salivary gland at this region, submandibular triangle, submandibular region. So this is the submandibular gland that is present, and it opens towards the floor of the mouth. As you know, this is the tongue, and it is open to the floor of the mouth. And sublingual glands are present over here. So they are opening diffusely. The name of the opening of the sublingual glands is called as Bartholin's ducts. Bartholin's duct. And the opening of submandibular gland, Wharton's duct, and parotid gland, the name is called as Stenson's duct. Where does the parotid open? Parotid opens, pierces the buccinator and opens into the crown of the upper second molar, crown of the U2M. Here is the opening of the parotid gland. You should keep it in mind. The submandibular, sublingual, they open in the floor of the mouth on either side of the frenulum like this. So calculi, the stones are more common in the submandibular glands because they have got a lot of mucus secretions, mucoid component in the secretions, and it is anti-gravity drainage. Anti-gravity drainage. So these serous glands are more common in the case of parotid glands. So these are the basics of your salivary glands. Of course, the tumors are very rare. The salivary gland tumors are important. Why? Because they are varied. Almost nearly 40 pathologies, 40 types of pathologies are there. So very difficult to understand and rare also. Therefore, you cannot just have a great experience in one's lifetime. You should keep it in mind. So I'm going to details of all these things. So we'll take almost 1 hour class, which we have to complete. We'll try to complete it most of the times. If not, we'll continue the next class. Salivary glands are more commonly having benign pathologies. Carcinoma is very less. Salivary carcinoma is very less. Salivary neoplasms possess some features which make them unlike other head and neck neoplasm. We are dealing with head and neck neoplasm, but some features which are very unique. Salivary neoplasms has got very unique features. Keep it in mind. There is a multiplicity of tumor types. I told you almost nearly 40 types of pathologies are existing and characterized by variable and diverse histological appearance. The histology is variable. So when a surgeon is there, he should have idea about the pathology and especially histology. Histology of what is happening inside the cell. Histology of what is happening inside the cell. That is why you should keep it in mind, all those things. The distinction between the tumor types, what are the types of tumor, and benign and malignant is very important, and various types of pathologies are existing in salivary glands. And it is very difficult to find out that easily with fine needle aspiration cytology and small biopsies. You cannot just differentiate all the tumors with FNESC, that is fine needle aspiration cytology, and small biopsies. You need a larger biopsy. So you need a large biopsy. You need a large biopsy for all these things. So you need a large biopsy for knowing and understanding all these things. You need a large biopsy for these things. The other important point about this salivary glands is benign tumor, which is most common. What is the commonest benign tumor? It is a pleomorphic adenoma. It is called as pleomorphic because of morphologies, various morphologies. As you know from pathology, pleomorphic adenoma, it has got a pre-malignant potential. I already told you, pleomorphic adenoma has got a pre-malignant potential, which is a unique tumor in the head and neck. A tumor with pre-malignant potential, which can turn out to be malignancy, is called as pleomorphic adenoma. PA, you can remember pleomorphic adenoma. Third important point is these salivary malignancies are characterized by indolent growth pattern, high tendency to recur. There is a high chances of recurrence. Recurrence is very high and gives rise to distant metastasis. Distant metastasis is also very high. So distant metastasis is very high, high recurrence and indolent growth pattern. Suddenly so they grow and aggressively they spread all over the body. So distant metastasis is high. Distant metastasis is very high. So recurrences may appear even after disease-free survival, and understanding of salivary neoplasms is important for an ENT head and neck surgeon. So ENT and head and neck, you should have a thorough understanding of salivary glands. So remember that this is all important as far as understanding is concerned. This is not exam oriented. Exam oriented, only 5 to 10 points are there all over the salivary gland that I will tell you during the course of the lecture. Okay, don't worry. Don't feel that you are burdened. You should understand the things and then you should remember things which are needed. That I will tell you. And surgical anatomy of the parotid gland. Now we could see, if you take the parotid glands, they are paired glands situated on either side of the face. They are situated on either side of the face between the ear and ramus of the mandible. So this is the ear, I am telling you, and this is the ramus of the mandible. As I told you, this is the ramus of the mandible. Here will be the location of the parotid gland. Superiorly, the gland extends above the level of EAC. Superiorly, the gland extends above the level of EAC. And where does it extend? Up to the level of temporomandibular joint. It will extend up to the level of temporomandibular joint. Temporomandibular joint. Superiorly to extend the level of EAC. So what you should say, this external artery canal superiorly till the level of EAC, and inferiorly where is the temporomandibular joint? Superiorly where is the temporomandibular joint? So in front of the EAC only, this is the external artery canal. If you take this is as external artery canal, this should be the temporomandibular joint. The upper limit of extension of parotid will be this particular EAC, above the level of EAC. Anteriorly, it extends superficial to the masseter muscle. You take masseter muscle, so which will be inserting towards here almost. So anteriorly, the extension will be towards the mass, that is masseter muscle. 20% of the individuals, a portion of the gland, that is accessory lobe, will be there. There will be an accessory lobe. It is separate from the main gland. It can be there on the masseter muscle and in proximity to the parotid duct. It is nearer to the parotid duct. So in 20%, the chance of accessory lobe is there. So accessory lobe is there and separate from the main gland, and over the masseter it is there near the parotid duct. The bulk of the gland, that is the tail, extends inferiorly. So imagine an animal whose tail is very big, that is called as the bulk of the gland. So this animal, for example, this parotid is an animal, the tail is very big. Okay, where is it? In between the mandible and upper part of the sternocleidomastoid. If you take this as the external artery canal, this is the mastoid process, and this will become the sternocleidomastoid, and this becomes the angle of the mandible. So the bulk of the gland is in between angle of the mandible and upper part of the sternocleidomastoid muscle. The bulk of the mandible is in between upper part of the mastoid and sternocleidomastoid muscle. Upper part of the mastoid, sternocleidomastoid and mandible. So between the mandible and sternocleidomastoid is the bulk of the gland. So that is why a lump that is present in the tail of the parotid, that is bulk of the gland. So the lump that is present in the tail of the parotid, that is bulk of the gland, is easily confused with upper deep cervical lymph nodes. Is easily confused with upper deep cervical lymph node. Where does upper deep cervical lymph node? If you take this is the mandible, below and behind the mandible will be the upper deep cervical lymph node. Below and behind will be the upper deep cervical lymph node. That will become the upper deep cervical lymph node. So that is the one which is confused with the tail of the parotid. So upper deep cervical lymph node or level 2 lymph node is easily confused with the parotid. Why? Because it lies between the sternocleidomastoid and then your angle of the mandible. Almost it is looking like a upper deep cervical lymph node. There may be an extension of the gland deep to the mandible, that is to the level of pterygoid process. Till the level of pterygoid process, you have got this parotid gland. Sometimes till the level of pterygoid process. Sometimes till the level of pterygoid process, your gland, that is parotid gland, may exist. Parotid gland may go till the level of pterygoid process. Parotid gland may go till the level of pterygoid process. Parotid gland may go till the level of pterygoid process. So as you could see here, so this is a cross section. If you understand, try to understand. So what are all the structures that are there? So this is the, as you could see, this is the uvula. So for example, they have made it as a uvula, and then this is the, so this is the jaw with teeth. Okay, jaw with teeth, and this is the mandible. Okay, so mandible is there here like this, and then as you could see here. So what is this styloid process? This is the styloid process. This is the styloid process. This is the styloid process. So from the styloid process, one muscle going here is stylohyoid muscle. Stylohyoid muscle. Okay. And this is the mastoid process. Imagine this is the mastoid process. So you, between the mastoid and mandible is the parotid gland. This is the parotid gland. This is the parotid gland that is present in the cross section, as you can see here. Okay. So this is the styloid process, and this becomes the stylomandibular ligament. This becomes the stylomandibular ligament. This becomes the stylomandibular ligament. So stylomandibular process and membrane. This is stylomandibular membrane or ligament, as you could see. So that is there. So from styloid process, one more muscle goes medially towards the tongue, that is styloglossus. So this is the styloglossus. Okay, this is the styloid process already done, stylohyoid done, and stylopharyngeus. Okay, and this is the constrictor muscles of the pharynx called as superior constrictor muscle. This is the superior constrictor, pharyngeal constrictor. You could see that. So once you take the styloid process, what are the muscles that are there? Towards the pharynx is stylopharyngeus, towards the tongue is styloglossus, and towards the hyoid bone is stylohyoid. These are the muscles that are there, which are intimately. From the styloid, you have till the level of mandible. This is the stylomandibular ligament. Stylomandibular ligament. This is the thing that you should keep it in your mind. Stylomandibular ligament. So all the important structures that are there. So as you could see here, this is the posterior belly of digastric, and you have got the sternocleidomastoid also. So posterior belly of digastric and sternocleidomastoid will be there. Once you see from the side, this is the mastoid process. This is external artery canal. This is the mandible like this, and this is the sternum like this, and then this is the clavicle like this. Okay. Sternocleidomastoid will be running like this. Okay, posterior belly of digastric, where does it run? It runs from here to the level of hyoid bone. This is the hyoid bone if you have it here, from here to here. So posterior belly of digastric is one thing which is related to facial nerve. Sternocleidomastoid is also one thing which is related to facial nerve. These three things you should have it in mind, but you are understanding that. Next, ducts of the parotid. The parotid gland is surrounded by a thick capsule. So surrounded by a thick capsule. Where is it derived from? The capsule is derived from investing layer of deep cervical fascia. Investing layer of deep cervical fascia. Okay, cervical fascia will have a class afterwards. Cervical fascia will have a class afterwards. After the completion of oncology, I will take the cervical fascia for you. The parotid gland is surrounded by a thick capsule. It is surrounded by a thick capsule derived from the investing layer of deep cervical fascia. Derived from the investing layer of deep cervical fascia. So deep cervical fascia, as you could see, superficial fascia, deep fascia. Deep cervical fascia has got some superficial or investing layer. Okay, superficial or investing layer. First layer is called as superficial or investing layer. It invests all the glands that is present. It invests all the glands that is present. That is investing the parotid gland. The parotid gland is there like this in a cross section. So this is a superficial part, and this is deep part of the cervical fascia. So this is very thick to this side superficially. Deeply it is very thin. Therefore, any swelling is there, it goes medially. Swelling of the parotid gland most goes medially. Histologically, there are many serous secretory units. That is called as acini. So many serous secretory units called as acini. So these are called as the acini. These are called as acini, which drain into intercalated are terminal ducts which drain. They go towards the intercalated or terminal ducts. Remember ICT, intercalated or terminal ducts. Intercalated or terminal ducts. They drain into intercalated or terminal ducts. The intercalated ducts converge to form striated or intralobular ducts. Okay, so acini, they go into intercalated or terminal ducts and they go into striated or intralobular ducts. Striated or intralobular ducts which converge to form the secretory or interlobular ducts. So they form secretory or interlobular, secretory or interlobular ducts. Secretory and interlobular ducts found within the connective tissue septate. The secretory ducts, they empty into the parotid duct. The secretory ducts, they empty into the parotid duct. This is very important. You have to remember. So acini are the main units. Acini, they go towards the intercalated ducts. Intercalated ducts or terminal ducts. You have to remember ICT. Intercalated ducts or terminal ducts. Intercalated ducts or terminal ducts. They go into secretory or interlobular ducts. Secretory or striated or intralobular. I'm sorry, striated or intralobular ducts. So they are striated or intralobular ducts. Striated or intralobular ducts. They are striated or intralobular ducts, which converge to form secretory or interlobular ducts. Secretory or interlobular ducts. Secretory or interlobular ducts. Okay. The secretory or interlobular ducts. So these are the striated ones, these are the secretory ones, and at the end of the day, they go into the parotid duct. The parotid ducts open at the level of upper second molar. They open into the main parotid duct. The main trunk of facial nerve, very important. For main trunk of facial nerve, enters the posterior surface of the gland. It bifurcates into upper and lower divisions. So in the facial nerve, for example, this is the parotid gland. The facial nerve enters the posterior surface and it bifurcates into upper and lower divisions. So this is the parotid gland. The facial nerve bifurcates into upper and lower division. In turn, it is split into further branches. So here, what you have to remember in this is very important. Serous glands or acini, they go into intercalated or terminal ducts. Later on, they go into striated or intralobular ducts. Later on, they go into secretory or interlobular ducts. Later on, they go into parotid duct, main parotid duct. So facial nerve. Now we are taking the facial nerve. The upper division of the facial nerve gives rise to frontal, zygomatic, and upper buccal branches. Okay. So when you take this is a parotid gland like this, there is the upper division and lower division. Upper division gives rise to temporal or frontal, okay, zygomatic, and upper buccal branch. The lower division gives rise to lower buccal, marginal mandibular, and cervical branches. The lower division gives rise to lower buccal, marginal mandibular, and cervical. So lower buccal, marginal mandibular, cervical. I already told you how to remember this one. To join Bhaskar Medical College. Students, you should remember to join Bhaskar Medical College or branches of facial nerve. Temporal, zygomatic, buccal, marginal mandibular, cervicofacial. Okay. So this buccal is divided into upper buccal and lower buccal. So this level is the upper part of the facial nerve. This level is the lower part of the facial nerve. You should keep it in mind. Upper division are thicker and resilient. Superficial. The upper part is thicker, resilient, and superficial. The upper division is thicker, resilient, and superficial. Thicker, resilient, and superficial. The lower division, so you say lower division is thinner, delicate, and deeper. So if you take upper part and lower part, so it is thicker and superficial and resilient. Lower part is thinner and it is deep to something else. So they are deeper. Lower part is thinner, delicate and deeper. Neuropraxia. So what is neuropraxia? That is just weakness of the occurs after surgical manipulation, especially in the lower divisions. So lower divisions are very much vulnerable for surgical damage. Lower divisions are vulnerable for surgical damage. Zygomatic and marginal mandibular branches, which are very much vulnerable. You should keep it in mind. So injury leads to functional and cosmetic problems. So injury leads to functional and cosmetic problems. So you should importantly remember is the zygomatic and marginal mandibular nerves, which are very important. So zygomatic nerve and marginal mandibular, which are very important. Zygomatic and marginal mandibular, very important. The facial nerve defines the superficial and deep lobes of the parotid. If you take the parotid gland like this, so once you open the parotid gland like a book like this, if you say this is the superficial lobe, this is the deep lobe, the facial nerve is going to say you what is the superficial and what is the deep part of the gland. So, but there is no histological demarcation between the two lobes. No histological demarcation between the two lobes. There is no histological demarcation. Both the lobes are histologically similar, superficial lobe and deep lobe, but only separated by facial nerve. Where does the facial nerve exit the skull base? Facial nerve exit the skull base at the stylomastoid foramen. Facial nerve exit the skull base at the stylomastoid foramen. Facial nerve exit the skull base at the stylomastoid foramen. There are landmarks for the facial nerve. You should keep it in mind. At this point, there are landmarks for tracing through the gland. What are the landmarks for the parotid? So, in the ear, you should have landmarks. In the head and neck, you should have landmarks. Head and neck. So, during otology, what are the landmarks that are there? 1, 2, 3, 4, 5, 6. You should keep it in mind. I already told you in facial nerve. And head and neck, you should keep it in mind 1, 2, 3, 4. So we are going to discuss about the head and neck landmarks only. So here, etc. I am just trying to revise that. Processus cochleariformis. Processus cochleariformis. Okay, oval window. Okay, oval window. And all the things which are there, you should keep it in mind, etc. And digastric ridge. Okay, digastric ridge. Tympanomastoid suture. Okay, styloid process, you should keep it in mind. All those things you should keep it in mind. Whereas in head and neck, you should remember about cartilage pointer, tympanomastoid suture, and then your styloid process. Styloid process, if you take, you should say SPM. Styloid process is medial. You should remember styloid process is medial. Styloid process is medial. So these are already dealt in your ear otology lecture, and these are the head and neck landmarks which you are going to see right now. Okay. So landmarks are facial nerve. So this is posterior belly of digastric. Okay, posterior belly of digastric. If you take this, for example, this is the mastoid process and this is the styloid process. Here is the stylomastoid foramen. Here will be the belly of posterior belly of digastric that is attached. From here, it will go there to the hyoid bone, and then it will go there, and then it is going towards the mandible like this. So when you lift the posterior belly of digastric, so you will reach the particular facial nerve exit. So that is posterior belly of digastric. So this particular P is the posterior belly of digastric. You should keep it in mind. Posterior belly of digastric. Posterior belly of digastric. Next, once again, you go forward. So you can go till the level of digastric muscle. You can superior to the facial nerve. Okay, and you can find the nerve just superior muscles upper border. If you say this is the posterior belly of digastric, you can find the nerve over here upper border. You can see the nerve. Next, tragal pointer. The deep cartilaginous landmark when you are dissecting. So, for example, this is the This is the external ear, and this is the tragus. Okay. When you see the tragus, it's like a pointer. Okay. 1 centimeter superior and 1 centimeter superficial to the nerve. This particular thing. So tragal pointer. It is called as tragal pointer. I already told you here. So this is a tragal pointer. It's the tragal pointer. CTSP is a tragal pointer. TP is a tragal pointer. So what is the distance? 1 centimeter from the nerve. Tragal pointer is 1 centimeter from the nerve. Tragal pointer is 1 centimeter from the nerve. It is superficial to the nerve. Next is tympanomastoid suture. Tympanomastoid. If you say this is the mastoid bone, if you say this is a tympanic plate, for example, tympanic bone is there. Tympanomastoid suture here will be here. Tympanomastoid suture. This is a tympanomastoid suture. Okay, you should call it as tympanomastoid suture. It is a hard ridge deep to the cartilaginous portion of the external artery canal. Once you are elevating, for example, this is the pinna. You are lifting it up like this, and then you can find this. After dissection, you can find this tympanomastoid suture. That is called as tympanomastoid suture. So this facial nerve emerges few millimeters deep to its outer edge. Deep to its outer edge. So deep, anterior, and inferior. You can remember DAI. So tympanomastoid suture, how do you remember? Deep, anterior, and inferior. That is nearly 1 centimeter deep, anterior, and inferior. You should keep it in mind. Deep, anterior, and inferior. So styloid process is medial. I already told you SPM. Styloid process is medial. The styloid process lies medial. It is not used as a landmark effort most of the times. Tumors of the parotid gland, they can displace the facial nerve anteriorly. Anterior displacement of the facial nerve occurs in the tumors of the parotid gland. They can displace inwards, outwards, superiorly, inferiorly, based on the location. So they can displace the facial nerve anteriorly, they can displace the facial nerve superiorly, they can displace the facial nerve inferiorly, they can displace the facial nerve outwards. All these ways. Anyhow, the facial nerve can be displaced based on parotid tumor. Parotid tumor can displace these things just like that. Parotid tumor can displace the things like that. So landmarks of the facial nerve, as you could see, so this is the tragal pointer, as I already told you, and this is the tympanic bone, tympanomastoid suture, and this is the posterior belly of digastric. You should keep it in mind. This is the ramus of the mandible. This is the zygomatic process. This is the coronoid process. This is condyloid process, and this is the mastoid process. All these things are there. Then the stylomastoid foramen, you take this like this. Okay. So lift the digastric, posterior belly of digastric, you will be able to see the facial nerve. And after all that, once the branches are patterned like this, you can go for retrograde dissection. Retrograde dissection. So if the ending of the branch is taken and then you go backwards and backwards and backwards, you can find the main trunk of the facial nerve. Where do you find the main trunk of the facial nerve? In between the upper lobe of the parotid and lower lobe. That is in between the book like this. Okay. So this is parotid gland and the facial nerve. And what about this greater auricular nerve? This greater auricular nerve, it courses superiorly over from the posterior border of the sternocleidomastoid towards the parotid gland. So once you take sternocleidomastoid like this, so and you have the parotid gland like this, the greater auricular nerve courses superiorly over from the posterior border of the sternocleidomastoid. From the posterior border of the sternocleidomastoid, this greater auricular nerve courses superiorly towards the parotid gland. So you can say greater auricular nerve this courses superiorly in this manner. So this is a greater auricular nerve. What is greater auricular nerve? Greater auricular nerve is supplying the pinna, lobule of the pinna. You can remember ear lobe, ear ring is one you cannot wear. In the parotid surgery, post-operatively the patient is not able to palpate the lobule. She cannot wear the earrings, not palpate the lobule. In the same way, thyroidectomy surgery, male cannot do shaving because of C2C3. C2C3 involvement, male cannot do the shaving because of loss of sensation. In parotid gland, female cannot put a earring. Female cannot put a earring. Female cannot put a earring. Okay, so that is how you should keep it in mind. Because of damage to the greater auricular nerve. Where does it come from? From posterior border of sternocleidomastoid, it comes from towards the parotid gland. It goes. So sometimes we have to sacrifice this greater auricular nerve. You have loss of sensation of the. You should say take the consent from the patient that you have loss of sensation of the ear lobule. You cannot wear your earrings without seeing the mirror. So which is you can take the cell phone outside. No, it's disturbing for the class. So leading to sensory deficit, which is most noticeable over the earlobe. Please take that away, causing disturbance if not put it in silence. Okay, posterior branch of the greater auricular nerve, it supplies the earlobe. So as we have seen, so earlobe is supplied by what? Posterior branch of the greater auricular nerve. Greater auricular nerve, it is causing supplying the posterior branch of the earlobe, and it has to be preserved. At least you preserve. So once you take the sternocleidomastoid like this, from here coming the greater auricular nerve. So there is a posterior branch which is going till the level of this earlobe only. You have to preserve it. What are the structures superficial to the parotid gland? They are skin, number 2 subcutaneous tissue, number 3 greater auricular nerve, as we have already discussed, greater auricular nerve, number 4 occasional lymph nodes. Lymph nodes might be present, occasional lymph nodes might be present. So lymph nodes are found deep to the parotid fascia within the parotid parenchyma. So within the parotid parenchyma, sometimes the intraparotid lymph nodes, they are called as intraparotid lymph nodes. So can you palpate them? You may not be able to palpate because it is tightly fit in the deep cervical fascia. If parotid gland is a person, deep cervical fascia is like a bunion. Okay, so you cannot palpate the lymph node within the intraparotid region. So you have got a retromandibular vein which traverses the parotid gland, deep to the facial nerve branches. Take this is the facial nerve like this. This becomes the retromandibular vein, which is deeper to this, particular facial nerve. This is deeper to the facial nerve. It is encountered in the inferior part of the gland. So retromandibular vein is encountered in the inferior part, especially along with the marginal mandibular and cervical branches directly over it. So if this is the retromandibular vein, you have got the marginal mandibular nerve and then cervicofacial nerve. Okay, just on it. So retromandibular vein, marginal mandibular nerve, cervicofacial on it, just on it. Keep it in, and they are just on it. The terminal branches of the external carotid artery. So external carotid artery, they lie deep to the retromandibular vein. So external carotid artery, they lie deep to the retromandibular vein. External carotid artery, they lie deep to the retromandibular vein. So if you take this is as a nerve, this is as a vein, and this is artery from superficial to deep, from deep to superficial. This is superficial. This is superficial. You have it here, and this is the deep thing that you have it here. So this is superficial. You have it here, and the deep thing you have it here. So these things you should be keeping in mind. Artery is always deeper in body, and vein is superficial to it, and nerve is more superficial to it. And this situation is very dangerous because it is a facial nerve. They are much less commonly encountered. Okay, deep to the retromandibular vein. So retromandibular vein is in the middle, and artery is deeper. You should keep it in mind. The deep lobe of the parotid gland extends medial to the level of ramus of the mandible. So deep lobe of the parotid gland, if you take this is the ramus of the mandible, so the deep lobe, which is the superficial lobe, is almost here, and deep lobe goes medial to the ramus of the mandible. Deep lobe will be going medial to the ramus of the mandible. If you take mandible like this, so this is the parotid gland superficial part, this is the parotid gland deep part. You should keep it in mind. Superficial and this is deep. This is the ramus of the mandible. You should imagine like that. The presence of the mandibular ramus constricts the glands at this point. The mandibular ramus is going to divide into two parts, like a dumbbell shape. It becomes like a dumbbell shape. Okay. Deep to the deep lobe, minor salivary glands are present in the parapharyngeal space. So when you go medial to the ramus of the mandible, this is the ramus of the mandible like this. This is the superficial lobe and then deep lobe of the parotid. This is superficial lobe and deep lobe of the parotid. This is the ramus of the mandible. So minor salivary glands are present all over the parapharyngeal space. You can say this particular part as the parapharyngeal space. Where does the parapharyngeal space lies? From the skull base to the level of hyoid bone. From the skull base to the level of hyoid bone. From the skull base to the level of hyoid bone. So from the skull base to the level of hyoid bone, you have the parapharyngeal space. It's called as parapharyngeal space from the skull base to the level of hyoid bone. The parotid duct extends from the superficial part of the parotid gland. So if you take the parotid gland like this, it extends from the superficial part of the parotid gland to the level of upper second molar. You should keep it in mind. And it is superficial to what? Masseter muscle. So superficial to masseter muscle. This is the masseter muscle. The parotid duct flows like this upon it. So this is the masseter muscle which is behind. A fingerblade inferior to the zygomatic arch. If we take this is the zygomatic arch of the temporal bone, this is the zygomatic arch of the temporal bone, and this is the masseter muscle, and this is the parotid duct which goes superficial to this above the zygomatic arch. At the anterior border of the masseter muscle, it pierces the buccal pad of fat and buccinator muscle. So this is the masseter muscle, it goes here and then pierces the buccinator, and below that will be the buccinator. Below that will be the buccinator muscle. Below that will be the buccinator muscle. So this is the buccinator muscle. It pierces the in front of the masseter. It pierces the buccinator muscle. It courses between the buccinator and buccal mucosa before opening the opposite the upper second molar. Upper second molar. As you have seen, so buccinator. So cheek we have seen, is it or not? Cheek. So in front of the upper second molar, it opens. In front of the upper second molar, the intraoral course. The intraoral course of the duct acts like a valve. Acts like a valve. It prevents the reflux. The intraoral course acts like a valve and prevents the reflux. So how is the reflux of the parotid gland duct prevented by intraoral course? By intraoral course. Intraoral course, it prevents that. And then coming to the submandibular and sublingual salivary glands. So keeping an eye on the submandibular, sublingual salivary glands, they are submandibular or paired structures medial to the posterior part of the body of the mandible. So if you take the body of the mandible like this from inferior view, you are seeing this will be the submandibular gland location. Each gland is composed of large superficial part and a small deep part. So this superficial part is large part and this deep part is a small part. They are continuous posterior along the border of the mylohyoid muscle. If you take this as the mandible, this will become the mylohyoid muscle. So this continuous posteriorly along the mylohyoid muscle. They continue like this along the mylohyoid muscle. You have it in your mind. So along the posterior border of the mylohyoid muscle, posterior part of the mylohyoid muscle. The posterior belly of digastric lies posterior to the gland. So when you take the posterior belly, this is the anterior belly of the digastric, and this is the hyoid bone, as you know. This is the hyoid bone, as you know. And then if this is the mastoid process, the posterior belly of the digastric goes like this. The posterior belly of digastric lies posterior to the gland. So if this is the gland, the posterior belly of the, this is the posterior belly of digastric which I am drawing here. This is the anterior belly of digastric. So this becomes a digastric triangle like this. And this is a submandibular triangle here. So anterior belly of digastric, posterior belly of digastric, and mandible, ramus of the mandible, body of the mandible, it becomes the submandibular triangle. Very important relation is the facial artery. The facial artery enters the submandibular triangle deep to the posterior belly of digastric. So if you lift the posterior belly of digastric, for example, this is the posterior belly of digastric, you are going to lift it, you can find the facial artery. So facial artery is there like this, and above which will be the posterior belly of digastric. So above which lies the posterior belly of digastric, related to the posterior and superior surfaces of the gland. It is related to the posterior and superior surface of the gland, and it emerges at the lower border of the mandible, at the anterior border of the masseter. So as you know, if you take this as the mandible like this from lateral view, it emerges from here, it goes like this. Facial artery goes like this and goes towards all the branches towards the face. Okay. So one of the branch of the facial artery, superior labial artery, which is present in the anterior epistaxis. Anterior epistaxis, that is Kieselbach's plexus. Kieselbach's plexus, that is anterior epistaxis, that is Kieselbach's plexus. So facial artery comes out like this in front of the masseter. If you take this is the masseter muscle, in front of it, it comes out like this. So that becomes the anterior border of the masseter. So before emerging as the lower border of the mandible and at the anterior border of the masseter. Superficial to the submandibular gland. What is there above the submandibular gland? There is subcutaneous tissue, platysma, and submandibular fascia derived from the investing layer. So this deep cervical fascia has got superficial layer and deep layer. It has got superficial, middle, and deep once again. The superficial part of this deep cervical fascia is also called the investing layer, or no, as you could see, investing layer. So it is also called investing layer. And then it is going to wrap up all the glands. So superficial or investing layer is going to wrap up all the glands, that is like submandibular gland and also the parotid gland. So submandibular gland and also parotid gland. All these things are wrapped up in the superficial or investing layer. So what happens is the facial vein courses superficial to the gland. The facial vein courses superficial to the gland and the digastric muscle on its way from face to internal jugular vein. So veins are always superficial, as I already told you. So this is the counterpart of the facial artery. So facial vein courses superficial and goes to the internal jugular vein. What are the important branches of the facial nerve here? Important are marginal mandibular nerve and cervical branches. You can remember MMC. MMC. So marginal mandibular nerve and cervical branch of the facial nerve lie superficial to the submandibular fascia on the gland, crossing superficial to the facial vein. So as we have already seen, the superficial one will be the nerve, and then the next superficial one will be the vein, and the next superficial one will be the artery, as we know. So if we take for the facial artery also, facial artery is the deepest, facial vein is the next one, and facial nerve is the superficial one. So where does this nerve actually superficial to the submandibular fascia overlying the gland? So they are on the gland. This marginal mandibular branch of the facial nerve is on the submandibular gland. You should keep it in mind. And also causing superficial to the vein. So they are superficial to the vein also here. So the marginal mandibular nerve curves superiorly and crosses the lower border of mandible close to the facial artery and supramandibular lymph node. So this, for example, if you take this is the mandible like this, you have the facial artery here, is it or not? So this is the masseter that is attached over here. The marginal mandibular nerve curves superiorly and crosses the lower border of the mandible close to the facial artery. So the marginal mandibular nerve, this marginal mandibular nerve is very important. It gives the lower lip. So when it is lost in the surgery, the lower lip will be drooling the saliva. So this is also there. Lower lip will be drooling the saliva. Lower lip will be drooling the saliva if it is lost in surgery. So where is it running? It is running close to the facial artery, and there is a supramandibular lymph node that is nearer to the supramandibular lymph node. Supramandibular lymph node. Hello, madam. Some disturbance is there. Hello. Please put your mic on mute. Please put your mic on mute. Hello. Hello. Please mute your mics. Please mute your mics. Hello.
Yes, sir.
Hello.
Yes, sir.
Please mute your mics.
Sir, I am muted, sir. Sorry for the disturbance. Please continue.
Hello. Yes.
Sir, I am muted and person was talking. Please continue.
So in order to avoid the injury, for example, when you are doing submandibular gland surgery, in order to avoid the injuries to the branches of the facial nerve, the submandibular fascia should be incised at the lower border of the gland, and dissection should be proceeding on to the gland. So incise the lower border of the fascia. So if this is a submandibular gland, incise the lower border of the gland, and dissection should proceed on to the gland deep to the fascia. So avoid marginal mandibular nerve injury during the dissection of submandibular gland. And if it takes the submandibular gland deep portion, the deep portion, it lies on the hyoglossus muscle, deep portion of the submandibular gland. So if you take this is a superficial portion, this is a deep portion. Where does it lie? It lies on the hyoglossus muscle. Hyoglossus muscle. And otherwise, the important structure here is the lingual nerve. It passes anteriorly and superior to the gland. The lingual nerve passes anterior superior to the submandibular gland. So lingual nerve passes anterior superior to the submandibular gland. And by the way, submandibular ganglia, there is one more important thing called a submandibular ganglia. Hello.
Yes, sir.
Some disturbance in the connection. Okay, now we are following up. So we'll try to end the anatomy today. So when you take the submandibular gland like this, you have got a lingual nerve, anterior superior, and hypoglossal nerve, because this is a submandibular gland, and this is a submandibular ganglion, and this is the lingual nerve and hypoglossal nerve below. And then the deep lobe is related to hyoglossus muscle. Hyoglossus muscle. Just remember these words. Do not worry about understanding and keeping in mind. So blood vessels are present between the gland and the ganglion, which required during submandibular gland removal. When we are removing the submandibular gland, blood vessels are present between the this is submandibular gland and this is the ganglion. In between, the blood vessels are present. This is the lingual nerve here. This is the hypoglossal nerve here. This is the hyoglossus muscle here. Okay. I told you about the hypoglossal nerve, which is inferior to the deep portion of the gland, is usually not encountered in simple submandibular gland surgery. So this is the hypoglossal nerve, that is called the cranial nerve. Okay, this is a lingual nerve, that is a branch of fifth cranial nerve. Okay, of mandibular division of the trigeminal nerve. You should keep it in mind. What is the duct called as submandibular gland duct? Is Barton's duct. It extends from the deep portion of the gland beneath the floor of the mouth, between the sublingual glands laterally and genioglossus muscle medially. So if you take that, this is the genioglossus muscle will be there over here. So genioglossus muscle will be there. The submandibular gland here. So when you take the Barton's duct, where does it pass? Extend from the deep portion of the gland. So this is the deep portion of the gland, and this is the superficial portion of the gland. Deep portion of the gland between the sublingual glands laterally and the genioglossus muscle. So if you take sublingual glands here and here, this is the genioglossus and this is the sublingual glands. The duct passes in between these two like this. To open at the submandibular papilla, this is the floor of the mouth wherein it opens. So this is the superficial lobe of the submandibular gland, this is the deep lobe of the submandibular gland, and the duct passes like this to open at this particular part. Once again, other side, superficial lobe and the deep lobe, and it is going up like this. So this is the sublingual gland. As you could see, this is the as you could see hyoglossus muscle that you could see here. Hyoglossus muscle that you could see here. Okay, this is the deep lobe and this is the superficial lobe. So how this is how you understand about the anatomy of the submandibular gland. So once you come to sublingual glands, they are beneath the floor of the mouth. They are beneath the floor of the mouth related to the submandibular duct. So beneath the floor of the mouth, when you take, this is the tongue and this is the frenulum, and this becomes a submandibular gland deep part, and this becomes a submandibular gland deep part, and superficial part. This becomes a lingual gland, and this becomes the hypoglossal nerve, hypoglossal muscle, and this is a duct that is passing like this and then opening here. And this lingual, sublingual gland, they open like this, in this manner. The lingual nerve winds around the submandibular duct, lying first lateral and inferior and medial surfaces. So what is the course of the lingual nerve here? You can say first it is lateral, next lateral inferior, next it is becoming medial. So once you take the submandibular duct, so if you take the submandibular duct from the deep lobe like this, lingual nerve first lies lateral, and then lateral inferior, and then it comes to medial. So lateral to inferior to medial, it comes like this. The lingual nerve course is like this. So what is the specialty of this lingual nerve? Lingual nerve supplies the sensation of the anterior two-thirds of the tongue. As we know, this is the anterior two-thirds and posterior one-third. So anterior two-thirds of the tongue, posterior one-third of the tongue. Lingual nerve via chorda tympani, and posterior one-third is glossopharyngeal. Via posterior one-third, it will be supplying like this. So lingual nerve is general sensation also, you can say. General sensation of the tongue by means of fifth cranial nerve. This chorda tympani belongs to seventh cranial nerve, as you know that. The lingual nerve also supplies the secretomotor fibers of these glands. So the glands has to function well, the lingual nerves has to function well, and also taste sensation. So secretomotor, that is the liquid that comes from salivary gland, secretomotor, that is by means of lingual nerve, and also taste by means of your chorda tympani nerve. You will be having it chorda tympani. The secretomotor and special sensory fibers, they derive from the facial nerve. I already told you, special sensory and secretomotor, they come from the facial nerve and reach the lingual nerve via chorda tympani. Already done, you know this. And if you take the minor salivary glands, I already told you approximately nearly 1200. They say 600 to 800. Some people say that 1200. That is also not wrong. Spread throughout the upper aerodigestive tract. So nearly 600 to 800 minor salivary glands are there. Upper aerodigestive tract, they'll be there. And most importantly, these minor salivary glands are there on the hard palate region. This is the hard palate means these minor salivary glands are more common, and tumors of the minor salivary glands are more common on the hard palate only. Should keep it in mind. So we'll just have an understanding of pathology for the last 10 minutes of this lecture, and then we go into details of it in the next class. So once you take the surgical pathology, salivary gland tumors are very rare. So they are nearly 3 per lakh. So 3 per lakh per year. You can remember how rare they are. And most of the time they are benign. The larger the size of the gland, they are more benign. The smaller the size of the gland, they are more malignant. Then malignancies are coming only for 5% of malignancies of head and neck. Malignancies they become and they form 5% of head and neck malignancies. Malignancies they form only 5% of head and neck malignancies. 5% of head and neck malignancies. And they are a pathological challenge. I told you nearly 40 types are there. You should be keeping in mind. They're very rare, difficult to diagnose them also. So malignancies of salivary glands they form about 5% of the whole of the malignancies. So why should you have a keep an eye on these pathologies of these salivary glands is that there are large number of different types of tumors that are present based on WHO classification, over 40 types, I already told you. They are characterized by morphological diversity. They are not looking like similar, and overlapping morphological features are there, prone to diagnostic confusion. There is always a diagnostic confusion based on this. There is always a diagnostic confusion based on this. And they are also rare, so difficult to diagnose, very difficult to diagnose pathologically. And subtypes are extremely rare, so that most pathologists have limited experience. The experience for the pathologist itself is very rare with these rare tumors. Nomenclature and classification is altering and altering and altering many times. Reclassification of the tumors has been done based on the diagnosis, and then nearly 1 in 3 cases. So 1 in 3 cases, they always have a doubt to put in which classification. Coming to tumors per se, 90% of the tumors of salivary glands occur in the parotid gland. They occur in the parotid gland. And almost 85%, that is 90% are in the parotid gland, 90% are all benign, as you know that. And among them, 80% of the tumors are pleomorphic adenoma only. So number one, top one position is pleomorphic adenoma of the parotid especially. Number two is Warthin's tumor. So Warthin's tumor, it is also called as adenolymphoma. Warthin's tumor or adenolymphoma. Warthin's tumor or adenolymphoma. The next most common, benign. So most common are benign. Top one is pleomorphic adenoma, and top two is Warthin's tumor. You can just remember Pakistan war. PA is pleomorphic adenoma. War is Warthin's tumor. Okay. So Pakistan war for India, Pakistan war is the most common in salivary glands. Pleomorphic adenoma and Warthin's tumor is the most commonest things that occur. The most common malignant tumor in the parotid is MEC, mucoepidermoid carcinoma. So mucoepidermoid carcinoma is number one malignancy in malignant tumors. If you take mucoepidermoid carcinoma is most common, and this is benign one, as I already told you. And number two is carcinoma ex-pleomorphic adenoma. Okay, so like your ex-girlfriend and ex-boyfriend, the ex-pleomorphic adenoma, you can keep it in mind. So carcinoma ex-pleomorphic adenoma is number two, and then third one is acinic cell carcinoma, ACC. So acinic cell carcinoma, ACC, acinic cell carcinoma. Adenoid cystic is ADCC. Okay, that is a different issue. You can keep it in mind. Number four is adenocarcinoma, NOS, ACNOS, ACNOS. You can say adenocarcinoma, not otherwise specified. So most common malignant tumors are mucoepidermoid carcinoma, number one. Number two is carcinoma ex-pleomorphic adenoma. Number three is acinic cell carcinoma. Number four is not otherwise specified. So adenocarcinoma, not otherwise specified. Number one is mucoepidermoid carcinoma. Number two is carcinoma ex-pleomorphic adenoma. Number three is acinic cell carcinoma. Number four is adenocarcinoma, not otherwise specified. And there is something called as ADCC. I told you ADCC, adenoid cystic carcinoma, and polymorphous low-grade adenocarcinoma are rare in parotid gland. They are rare in parotid gland. Adenoid cystic carcinoma and polymorphous low-grade adenocarcinoma are rare in parotid gland. Of note, the parotid gland is common site. So other squamous cell carcinoma, they metastasize into parotid gland. They metastasize into parotid gland. And malignant melanomas arising in the skin of the head and neck. So squamous cell carcinoma and malignant melanomas of the head and neck, they go into the region of temple. So squamous cell carcinoma and malignant melanoma of other sites, they attack the parotid gland. They attack the parotid gland. They attack the parotid gland. Such metastasis typically outnumber the primary tumor. So in some countries like Australia, the metastases are more common than primary tumors. And next point, important thing is in submandibular gland, I did not edit this one, of course. Submandibular tumors are less common than parotid tumors. So submandibular tumors are only 11%. If you take parotid as the most common, followed by submandibular, followed by sublingual. Okay. So they form 4 to 11% of the total tumors. Half of them, as the size decreases, the malignancy increases, I told you. So in parotid, almost 80% are pleomorphic adenomas, but in submandibular, only 50% are pleomorphic adenomas. In submandibular, only 50% are pleomorphic adenomas. So submandibular gland, 50% are benign and 50% are malignant, and 50% are malignant. Submandibular gland, 50% are benign and 50% are malignant. So most common malignancy in submandibular gland is adenoid cystic carcinoma. So whereas in sublingual, in parotid gland, most common carcinoma is mucoepidermoid carcinoma. So most common carcinoma in parotid is mucoepidermoid carcinoma, and most common carcinoma in submandibular is your adenoid cystic carcinoma, ADCC. So ADCC is different. So adenoid cystic carcinoma is the most common. And first one is adenoid cystic carcinoma, next is pleomorphic adenoma, mucoepidermoid carcinoma, non-Hodgkin's lymphoma, and squamous cell carcinoma. They are all reported in the submandibular gland. You keep it in mind. Over half of the intraoral salivary glands are benign. So if you take intraoral salivary gland tumors, so they are benign, half of them are benign, and most commonly the pleomorphic adenoma once again. So as the size decreases, the malignancy ability increases, but even then also half are benign. So once you take canalicular adenoma, number one is pleomorphic adenoma, number two will become the canalicular adenoma. This is the last slide. We are going to stop after this slide. So canalicular adenoma is the most common, next most common benign tumor. First one is pleomorphic adenoma, second one is canalicular adenoma. This is all in the submandibular gland, that is in the oral cavity, within inside oral cavity. The most common malignant tumors is mucoepidermoid carcinoma, okay, followed by adenoid cystic carcinoma. This is the intraoral malignancy that you can say. Next, followed by polymorphous low-grade adenocarcinoma, mucoepidermoid carcinoma, adenoid cystic carcinoma, polymorphous low-grade adenocarcinoma. These are all the intraoral tumors. The intraoral tumors, these are not submandibular gland, it is intraoral tumors. The most common site for intraoral is the palate. As I already told you, it is in the palate, and followed by upper lip and buccal mucosa. Palate, upper lip and buccal mucosa. Palate, upper lip and buccal mucosa. Palate, upper lip and buccal mucosa. They occur in the upper lip, most commonly they are benign, and the lower lip, floor of the mouth, lower gingiva, retromolar trigone are most likely to be malignant tongue. So when you take, we have already completed all these things. Upper lip are more commonly benign, lower lip are all more commonly to be malignant. Minor salivary gland tumors are more common in females, except for adenoid cystic carcinoma with equal. Adenoid cystic carcinoma male equal to female. Adenoid cystic carcinoma male equal to female. Adenoid cystic carcinoma is male equal to female. And tumors of the sublingual gland are very rare, and the most malignancy is adenoid cystic carcinoma is the most important reported. So submandibular and sublingual, the most common is adenoid cystic carcinoma as well as carcinoma is concerned. Okay, intraoral tumors, as you could see, is your mucoepidermoid carcinoma. Intraoral is, that is a small salivary gland. Intraoral, you can say mucoepidermoid carcinoma. So this is how we complete the introduction of salivary glands and salivary gland tumors. We will complete in the next class about the whole of the salivary gland topic. According to me, so these are not at all important as far as your exam is concerned, but while understanding this, you can understand the concepts of facial nerve, you can understand the concepts of the anatomy of parotid, submandibular, sublingual glands. The understanding is more important than exam. exam you have to understand many things and master and write as a single section. So facial now we have covered most of the anatomy of parotid glands, submandibular, sublingual glands, and based on that the pathology of the glands are also covered. So based on it you can understand it very easily. There's a small chapter in your textbook, you can read it as well. Thank you.